All right, we are back, Senate Health and Welfare Committee, and we're now looking at our mental health bills. We have three different bills, and we're looking at maybe putting those bills together and perhaps adding some language to the bills to make them a little more robust. Any bill that we introduce can always use improvement. We'll
Robustness.
see how that goes. So, Kristen Chandler is here, the training coordinator for Team 2. And Kristen, thank you for being here.
Well, good morning. Good morning, committee members, and thank you, Madam Chair. And thanks for accommodating my schedule this morning by allowing me to go first here. We've got some great people lined up to testify. I will say, so I do have my Team 2 coordinator hat on today. I also am the vice chair of the Mental Health Crisis Response Commission and the co-chair of a CIT exploratory group in Washington County that stands for Crisis Intervention Training. And I run a group in Randolph that is looking at mental health resources as well. And I will say I was really excited when I saw these bills. Team 2 training is a statewide training. It's been in existence since 2013. And I travel all over the state because it's offered in 5 different regions. And at every different region, there are different resources available to first responders. It's a training for police and mental health crisis workers, dispatchers, EMTs are also invited. Sometimes there are emergency department personnel who attend and state's attorneys. But it's primarily to build relationships among first responders so they can better collaborate in responding to mental health crises. So while I go around the state, I have been able to see over the years the varied levels of response and an ability to respond mobily to mental health crises. From the PUC program down in Bennington up to the community outreach program in Burlington, it really depends on where you are in the state as to what you can expect for a response in a mental health crisis. Different mental health agencies have programs for kids, for adults, for people who with an intellectual disability versus a mental health crisis. They have different teams that might respond to those. But the consistent thing that I hear from mostly police and mental health crisis clinicians is that we need more resources. We would like more options about where we can take somebody. And so the peer respite idea, I think, is fantastic. I've been familiar with Alyssum for years since it started. So I'm really encouraged by this initiative to start additional peer respite programs in different counties around the state. The crisis, the S197 to form a working group to sort of coordinate all the various crisis responses. I was able to listen in last week and I heard Fox's testimony and other people's testimony about that. I will say there are a lot of different initiatives going on around the state, but because of the different resources that are available in different regions, I'm not sure how coordinated a response can be, because that's really the key, is what's available in a particular region in order to have a crisis response. And it just can really change depending on where you are. So, and any kind of working group, I think it's got to be manageable. Obviously, I've been on a couple of different legislative working groups in the past. And if you do decide to form one, I hope that it can be with manageable numbers and with the right people around the table. I think the people who are actually doing crisis work really need to be there, because they're the ones who really know what's working and what isn't. I will say, I did hear Fox mention the use of force policy, and I'm not sure this committee is familiar with that, but that is a policy that went statewide. It went into effect on October 1st, police use of force. And it came out of a governor's initiative after the legislature passed the change in the use of force law. And as of October 1st, it really has changed. It's affected how we can respond to mental health crises. And now mental health crises workers are finding themselves along with EMTs, sort of trying to figure out how to respond without police being present. The use of force bill allows police to have an option now that if a person is alone and suicidal, that they don't, and they have a weapon, that they don't have to respond. And we're trying to come up with alternative models where we don't have police respond as much. And there's a lot of people working on that. But it's really changed how mental health crises responds. And a lot of people, when they call 911, they're now being told, well, you need to call your local mental health agency. And so the onus is going back onto crisis workers. And I think, I'm guessing that Karen Curley is probably going to speak about that a little bit because it's really impacted their work. One thing I will say about the police have been responding. Team 2 is not a mandatory training. The mandatory police training we have in Vermont is 8 hours of what you may be familiar with. It's called Act 80 training, or responding to a person with with mental health crises. And I teach that at the police academy, along with a clinician and a police officer. And we also teach it. It's required for any part-time or certified officers who might transfer in from another state. So we also teach it around the state when it's needed. But that's all the training police get that's required for mental health response. Team 2 is optional, and I'm really fortunate that a lot of police agencies have decided to attend and are benefiting from it. Since its inception, we've trained over 650 police officers and 450 mental health crisis clinicians. But unlike other states, we do not have a mandatory follow-up mental health training. And it's my opinion that would make sense to have 4 hours every 2 years to follow up with mental health training. Because I can have people come to my training who've been a police officer for 20 years, and the last time they got any mental health training was 20 years ago when they were in the academy. And given how the laws change and the resources change every single year, it's really imperative to have updated mental health training and a refresher. And I would love to see Vermont make that a mandatory thing for law enforcement, just as other types of response are mandatory for police, like domestic violence response, certification on their firearms use and their taser use, things like that. So that's sort of, I know that's not encompassed in any of these bills, but I just wanted to let you know about that. That is the state of affairs here in Vermont. I will say that the Vermont State Police a few years ago identified Team 2 training as a priority, and they are trying to send all of their troopers through the training. There are only very few police agencies who've never attended Team 2. And the Vermont State Police has expanded their mental health training. They've added a couple of hours to their basic academy, where I go in and meet with their recruits and spend about 2 or 3 hours with them, just talking about the mental health system in Vermont. And I do a post-basic training with them as well, where we run through some scenarios, and I occasionally will bring in an actor, and we'll actually act out some scenes, and I'll provide some observations in response to them. And that's what Vermont State Police has done to expand their training. It's up to individual law enforcement agencies to decide what kinds of mental health training they're going to receive. And fortunately, a majority of them have decided to attend Team 2 training, which is great. We always offer a person with lived experience in the training. We talk about the updates in the law. We do 3 different scenarios, and we talk about the resources that are available. And that just helps build the relationships that are necessary for a collaborative response. And everybody learns people's limitations, their language, and what they can expect the next time they go out in a crisis. And that's really why, with the change in the use of force law, that's been our focus with the training this year on the legal update, is how that impacts the response and what people can expect from that. And it really helps. Everybody always comes away learning something about how their counterparts actually do their work. So that's really what I had to let you know about today, and I'm happy to take any questions if you have them.
Thank you very much, Kristen. That's very helpful. Can you send us your testimony in writing? So send it to Aaron and he'll post it. That'd be terrific.
I will.
Yes. And some of the comments that you've made, I think, will be very helpful in modifying and changing at least the workforce piece that's in there. I have workforce on my mind. Sorry, the task force working group piece, and even changing the title. So thank you.
Great. Okay. And
That's
I will
great.
say one of the reasons I have to get off of here early is because because I'm representing New England, I'm representing Vermont in a New England conference to showcase what we're doing here for training, because really no other states are doing it this way. And so we've been to international conferences, and I've learned that really here in Vermont, this type of training where we're bringing all these different people together in a room, for the first time, is really not done anywhere else around the country. So we are very forward thinking, I think, in our mental health police training. So that's a really great thing for Vermont.
Yes, and thank you for being one of the leaders in that. We really very appreciative of your work.
Thank you.
All right, I think we're going to move on unless there's a burning question of understanding here, and we'll look for your written testimony. Okay. Is there anyone else that has a schedule conflict coming up? Okay. Allison, yes, you are next on the list. So Deputy Commissioner of Mental Health, welcome, and we'll listen to your testimony.
Thank you for having me. So representing the Department of Mental Health today, I want to second Christian Chandler's comments. We too see this, particularly this peer initiative, as a good thing. We want to see more options for people who are experiencing crisis. And so my role today is really to orient this committee into some activities that have occurred since last legislative session to make sure that you're aware of these additional funding opportunities that have come our way and some plans that we have that are very well aligned with these topics. And so I'm going to give a brief overview of those related to peers, and then I'm going to pass it to Laurel Omland, our Director of Children and Adolescent Families, to talk through some of the mobile crisis initiatives. So we just did want to highlight, and I will say it's nice to come to a committee and say, oh yes, we share that idea and we actually have some plans to address it very well aligned with what you have written. I know that doesn't always get to happen. So we do have that with the peer bills. And so we did put into, it's in the AHS budget adjustment, $30,000 to support a grant for the purpose of developing a process for peer certification. And that includes pulling together a stakeholder group, having people who really understand this work, then dig into the details of what needs to happen in order to get this across the finish line. And then from there, the ask is for this group to do some development and implementation of a statewide peer support specialist certification program. So you'll see that in the BAA. We have the grant written. We're really just with approval of that BAA, we would be able to move forward and push that out the door. And so we're excited to be a part of that work. We just wanted to make sure that the committee was aware of that piece, and that if you do decide to go forward, that we could make sure that these initiatives were aligned, and we'd welcome the chance to come to the table on drafting language if possible. And then in terms of our mobile crisis TA planning grant, there was an opportunity that came our way from the federal government, and we did also want to make sure we had a chance to detail that for you. And so I would invite Laurel Omland to speak to that.
Thank you, Allison. Good morning. I was about to say good afternoon. Really appreciate the opportunity to talk about this. For the record, my name is Laurel Omland. I'm the Director of the Child, Adolescent, Family Unit at the Department of Mental Health. And we did want to share an update and really kind of contextual information about this opportunity that was afforded to us under the American Rescue Plan Act. So a couple things were in that act that you're probably already familiar with, but just to briefly summarize, there's an opportunity in there for a new Medicaid state plan option to cover community-based mobile crisis services. And that opportunity begins April 1st of this year. So that is something that we're interested in exploring. And with that, the Centers for Medicaid and Medicare Services are offering an enhanced 85% federal match for qualifying expenditures for the first 12 quarters. So essentially 3 years from implementation of that new covered service under Medicaid. So as we've been talking with our partners across AHS, including our Medicaid policy folks, this is something that we are very interested in pursuing. And then the other component from the American Rescue Plan Act was this $15 million for state planning grants. And so we actually applied for that. Department of Vermont Health Access was the primary applicant, but they pulled together a group across AHS to be involved in that preparation of that proposal. Vermont did receive one of 20 of those awards. So we do have a planning grant from the Centers for Medicaid and Medicare Services to prepare for that expansion of community-based mobile crisis intervention under the Medicaid new option. So that award is over $950,000. It's for 1 year, and it started in September and goes until next September. Actually, I apologize. It started September 30th of 2021, so essentially October. But really, the majority of those funds are going towards a technical assistance contract with an entity called Human Management Associates. They were identified through an RFP, request for proposals process. And that contract has just gotten underway this past January. And I wanted to talk a little bit about what that's engaging and what the purpose of this planning grant is, because I think there is alignment with what the intent of the bill is for our state. So just to note also, the remainder of those funds is going to be in support of provider trainings to prepare for this initiative, and also any state system upgrades that need to happen related to a new covered service. So really the intent and why we were really excited about this opportunity for the planning grant was it gives us an opportunity to do that planning and to have a robust process with all the state entities who are involved in any type of mobile crisis, because there are many of us. It's not just Department of Mental Health. Clearly you've heard some of the other work through Kristen. Departments for Vermont Health Access have a role in this, DMH, but also Department of Aging and Independent Living, Disabilities, Aging, and Independent Living, our Department of Health through the Alcohol and Drug Abuse Program, and DCF Family Services Division all have great interest in how can we have a system that is better coordinated across the age span, so children, youth, families, adults, older adults, and across needs, so mental health, substance use, developmental disabilities, and any of the aging impacts. So we really want to be thinking about where we can coordinate. Let's do that. There might be some need for more targeted specialized components, but we still understand it within a coordinated system of crisis response. And how can we best leverage a new Medicaid covered service to support some of that? So this planning grant, well, before I get to that, I just want to define, according to Center for Medicaid and Medicare Services, they have provided some additional guidance to states that came out in December, I believe, for informing us about what are these qualifying community-based mobile crisis interventions that could be covered under this new benefit. So it does involve a multidisciplinary team, and they specify there needs to be a mental health professional who could be paired with a different type of position. It could be a peer support specialist, it could be a nurse, it could be a case manager or a behavioral specialist, but that is a teamed approach and multidisciplinary, who are trained in effective trauma-informed care, de-escalation techniques, harm reduction, that they screen and assess, they stabilize, provide some de-escalation, and then coordinate with other supports as needed, and really maintain that relationship with the necessary community partners, that there's a response in a timely manner, that is available 24/7, 365 days of the year, that there is an immediate, the benefit can support the immediate crisis response, as well as any follow-up in the near term follow-up to that particular crisis. And then it was clear that states actually, we have some flexibility in determining the composition of those crisis teams, the model that is implemented to carry that out. And even there's not a statewide requirement, if that makes sense. So what is needed in, say, the Northeast Kingdom might look different than what's needed in Chittenden County. So that's why we really felt like having a technical assistance entity who has a national lens, has a sense of how other states have developed some of these, would really be beneficial in helping us figure out, how do we want to do this? How do we, the first phase of what they're going to be doing is a needs assessment. That's occurring from February through March. Yep. So they've just begun to gather information. And then there's going to be a very robust stakeholder engagement process. And that will include a lot of the entities that you've named in the bill, and including, hospital emergency departments, schools, primary care providers, providers themselves, advocates, consumers, anyone who would use the service or has interest in it. And then they will help us design what that covered service benefit could look like under Medicaid, and support some implementation planning, like what workforce development recommendations would they have for us. So it is a lengthy, intensive, time-limited process that is resourced from the federal government through this state planning grant. So we just wanted to make sure that you were aware of what that was and how that might inform consideration of this bill.
Thank you so much. Greatly appreciate it. And you've more or less expressed some of the level of frustration that I had as I started to think about the state responses to mental health crisis. Not that each one isn't being done appropriately, but we have so many needs across the state and they are all different. And then being able to provide resources in each area of the state. So this is very helpful. Do you have your testimony in writing?
I can provide it that way. I also just realized, and I do apologize, I left out the, very importantly, another partner in this is the Department of Public Safety and the new mental health program director there. So he is a part of this conversation as well. I apologize.
Yes, we get that. This is very good. And I mean, my concern continues to be that the Department of Mental Health play the leadership role in any training, or at least some kind of umbrella over the mental health response that we have in our state. And I'm pleased to hear that that's happening organically. And so thank you for that information.
Thank you.
Any questions for our two Deputy Commissioner Crumpf or Director Ormond? Senator Hardy.
Thank you, Madam Chair. So Laurel and Allison, thank you both for your testimony. And it sounds like this sort of coordinated statewide planning and action steps kind of thing is already happening, in part because of this grant, but also because of the work of DMH. And I'm really interested in building, if we're going to do anything, building on what's already happening and not getting in your way. And also realizing that you and your staff and everybody, pretty much everybody on the planet is overwhelmed right now, and creating new requirements and new groups to do things just because we think it sounds good. I'm not interested in doing that. So if there are things that you think we should do to help you with these efforts, to language or whatever, I'm interested in that. But if you feel like you've got it and you're doing it, then I just want to get out of your way and let you do your good work. So please be really specific about if there's something you need us to do, and then if there's something you don't want us to do. So thank you.
Thank you, Senator Hardy. We do appreciate that. And I think I would just note that, there's a lot of mental health need out there right now. So I don't think any one of us would say on the record, we've got this, we don't need anything. But in this case, when it comes to a committee, I do think there's a lot of pieces that are in place to have that stakeholder engagement. And then I do think we might, between this committee and ourselves, have some ideas of where are some pieces that are still missing. And I really appreciate the opportunity to help you figure that out.
And I think that's the whole point of taking testimony on a bill like this, which is pretty in draft form. And it would be extremely helpful to have your comments on how to make improvements. So I think we're all in agreement with that. So if you could send your comments in writing, and then as we need to, we'll bring you back in and we'll go through any changes that we make legislatively.
Thank you.
Thank you. Thank you both for being here. Okay. Well, one of the issues that we continue to hear about, of course, is the mental health needs for our children, not all of which fall under the sort of the immediate crisis response, but it is a crisis response when we see them lined up in an emergency room, and the need for child psychiatry and other support being at a dearth. But so I've invited Dr. McGowan in to please comment on where we are and perhaps some recommendations that you might make and about kids and adolescents. Thank you for being here. I know how busy you are.
Thank you so much for having me. I'm really grateful to be here. Good morning, everyone. It's a privilege to be with this the others invited to speak as well. Like, challenging work is happening around the state in a state of crisis. And I think there's a lot of solidarity amongst all of us on the ground. So my name is Haley McGowan. I'm a board certified child and adolescent psychiatrist based at UVM Medical Center. Senator Lyons asked me to share my perspectives on the treatment of children for psychiatric emergency and what is needed to close the gaps. So about 2.5 years ago, just to give you a little background, UVM Medical Center created my position to help meet the community's longstanding child mental health needs in the hospital setting. So I was the first child psychiatrist assigned specifically to the emergency department. I also co-direct the Joint Child and Adolescent Psychiatry and Psychology Consult Program, which serves the medical floors at the hospital as well. So in my role, I've cared for hundreds of children for whom the general emergency department was their best option for acute mental health needs. This is most commonly related to suicidal thoughts or behavior, but also includes agitation, aggression, psychosis, mania, and really anything else that threatens a youth's safety in the community setting. So what this also means in terms of my role is that nearly every child who has boarded in the emergency department over the past 2.5 years has been under my care. So for better or worse, my passion for this is personal. Children and adolescents came to the ED and waited for mental health treatment long before the pandemic. But 2021, just to give you an example, saw a 111% increase in patients seen by my service in the emergency room. To give you an idea of where we are now, that means, so this Monday morning, there were 11 youth in the UVM Medical Center Emergency Department for mental health needs, and their average length of stay at that point was 11.2 days. If we include children waiting elsewhere in the hospital for whom we do not have appropriate placement, the average wait then extends to 15 days. So, I mean, you've heard it before, and I don't really think I need to belabor the point, but this doesn't happen for medical patients. What does unfortunately happen for medical patients, however, is their care can be delayed because of the strain that mental health patients place on an emergency department that is not designed to care for them. My colleague, Dr. Christian Pulcini, who's a pediatric emergency medicine physician at UVM, testified to this earlier this week and has before. Dr. Pulcini has also been immensely helpful in terms of data collection to capture our experience and the experience of children and families. And so needless to say, we are a united front. So I'll be honest, it's heartbreaking work supporting these children and families day in and day out because my team, in conjunction with First Call, so that's Chittenden County's crisis service, spends what feels like most of our time trying to cobble together creative but totally insufficient plans for children and families because we can't connect them to what they need. And so, you know, as a specialized physician, I've been extensively trained to assess what a child needs and to know what the evidence supports for good outcomes. And we can rarely provide it in a timely way. And often we can't provide it at all. And what's worse is that we actually have to watch children get worse before our eyes, decompensate in the emergency room and before their parents' eyes, because they're trapped in the counter-therapeutic environment that is the emergency room. So I mean, the emergency room is it's an absorption point for the stress of the healthcare system. It's a difficult lens to have. I mean, in this setting, my team doesn't get to experience much of the good news, but I'm increasingly aware of the exceptional work that's happening in the community across the state and really the noteworthy efforts to implement systemic change. But I will say the people doing the work are exhausted. UVM certainly fields the highest volume, but relative to emergency departments around the state, we're really well resourced. We have child psychiatry, we have child life support services, we have nurses with psychiatric training, case management. It's not enough because it's decidedly not treatment, but we're doing what we can to soften the stay that just keeps getting longer. This includes creating new physical spaces in the hospital for patients to await placement, coordinating and bolstering outpatient supports when we can, training staff on trauma-informed care and de-escalation strategies, seeking to provide more support to families. It's the right thing to do, but I don't want it to be a distraction from the greater needs because it shouldn't have to happen, to be honest. So I'd like to briefly offer my take on the gaps in care. And I don't offer these in isolation. I speak regularly with colleagues around the region and state who have been working in child mental health far longer than me for decades in Vermont. And what Vermont is lacking is a continuum of care. So do we need more capacity at the inpatient level? Of course. But with investment in the right intermediate services, the demands on the inpatient system would be far less. We need geographically diffuse programs outside of hospitals. So I think about this in three categories. The first is partial hospitalization and intensive outpatient programs. I'm going to try not to use too much lingo or explain where I can. So these programs are programs that provide intensive mental health treatment, but kids sleep at home every night. Importantly, and these exist for adults too, and they existed where most of my colleagues and I trained. These can be step down or step up programs when outpatient supports aren't enough, but they can also be stepped down from inpatient level of care. And that really helps support efficient throughput. So, so often kids are getting stuck in our higher levels of care, hospital diversion programs, inpatient psychiatry, because there's just no step down. There's no place for them to go to make a safe transition back to the community. The second bucket is brief crisis stabilization. An example is the PUC program in Bennington, which has been in lots of conversations. These are programs that give kids a few days to stabilize in a safe setting. They create an opportunity for intensive but short-term therapeutic interventions and creation of treatment plans. And then the third category involves far more investment in intensive home-based wraparound services that support kids in their communities. So for me, under this falls respite services for families and mobile crisis, which is just so encouraging to hear how that's moving forward. I think mobile crisis prevents kids from ending in the emergency department. They come here as the first stop, come to me as the first stop most of the time. But I will say crisis does a great job whenever possible of keeping them in the community. It's just impossible sometimes due to the acuity and the lack of resources to support them. Many children that we see do not need a secure inpatient child psychiatry unit. They don't even need psychiatrists like myself. We're just not the lifeblood of this work. To name a few, it's residential counselors, community first responders, therapists, skills workers, school-based clinicians, respite providers, case managers, and anyone who provides family-focused treatment services. So that leads me to sort of my final point. I really feel like Vermont needs to appropriately value and compensate the work being done by these foundational members of the care team. I don't really want to sugarcoat this. I've been pretty shocked to learn how undercompensated those providing direct clinical care to our most vulnerable youth are. It is often complicated and emotionally grueling work. And if we want to keep these talented and caring individuals in the roles that they want to serve, we need to compensate them in a way that is motivating and that recruits and maintains the most skilled and dedicated people. And it makes people want to stay in mental health care in Vermont. So I'll finish by saying that I think the right conversations are happening, and these initiatives are being pushed forward at all levels related to mobile crisis, community programs, and workforce retention. The American Rescue Plan Act, federal funding, and other grants have created some really rich opportunities. I feel hopeful. Vermont isn't alone in what often feels like an insurmountable challenge. This is very much a national story, but Vermont is a small state built on community and relationships and grit. And I really believe that with the right vision and allocation of resources, we have an opportunity. I think it has to be an allocation of resources commensurate to how we value this rising generation of Vermonters. We could become the gold standard, an example to the rest of the country of what's possible. So like I said, I'm hopeful. I'm really grateful for the opportunity to speak about this in any setting. It gives me sort of an avenue for this passion that gets pent up with lots and lots of kids in the emergency room. So thanks again, and I look forward to any questions.
So thank you so much. It's very comprehensive, and we greatly appreciate both your time and your professional expertise. Can you send us written testimony?
Sure.
That would be great. The other thing is, as we go forward and make some decisions, it would be helpful to have your input on whatever we decide. And for example, we had a school superintendent come in talking about what the mental health needs are in our educational institutions, or for kids, and the schools can't handle the level of need or the level of mental illness that is in the school. So my thought, and I'm running this by you, that's why I'm bringing it up. My thought was, well, a few years ago, we said, let's put a mental health counselor in every state police barracks. Maybe what we need is a designated mental health counselor in X number of districts across the state, or available to serve our schools. We probably can't do every school, but somehow, as you have said, we need to fill the gaps for the needs that are there, and maybe stop it before the kids get into the emergency room. I don't know what your thoughts might be about that.
I will say they exist. School-based clinicians are foundational to our work, and they're the ones who manage so much in the schools, and they only come to the emergency room because they couldn't do anything else. Like, they did everything they possibly could to keep that kid safe at school. But they like so many of us, they don't have supports once the kid leaves school, right? The family's sort of on their own. The kid is incredibly high risk. And so, when we can build teams around these kids and support the families and allow, access to pager service or, crisis intervention, that I think that's where this coordination piece is so essential. I heard a family describe it once as the way it feels in Vermont when you're trying to access services for your kid is you have to open like a million little doors before you finally find the one that has, that what you need. And that just really spoke to me, because I see so many people doing such good work, in silos, and the coordination piece is so important. Like, we can maximize and optimize what we have, but we also do need the additional resources. So yeah, I feel like there should be mental health support in every single school. Yeah, I would support that.
So what would be helpful is the silo issue is one that we hear about quite a bit. And I like the idea of the little doors being opened, because families need to have the key, and they don't have them. They don't know that it's a silo out there.
Right.
Exactly. Oh, okay. Questions committee for Dr. McGowan. Senator Hooker.
Thank you. And thank you, Dr. McGowan, for being here. I'm really concerned about the kids who are in the ER and they're there for a week or 11 days or 15 days, and curious to know what is happening with them. Where do you send them?
You mean after they leave the emergency room or while they're there?
Right, after they leave the emergency room.
So it's interesting. Yep. So usually they're waiting for a higher level of care. So we see a few things. We see waiting for a higher level of psychiatric care, and that might mean inpatient hospitalization, which our option in the state is Brattleboro Retreat. But we can also send a certain cohort of kids to CBPH in Plattsburgh. And we do send kids out of state when we can. Four Winds, actually, in Saratoga has recently been taking a handful of our kids. We have some contracts with other out-of-state places like Hampstead Hospital in New Hampshire, who will take Vermont Medicaid, I believe, but they have to prioritize New Hampshire, and they are in underwater as much as we are. So they're pretty rarely taking Vermont kids. So often they're waiting for a higher level of care and just no beds exist. Sometimes it's a placement crisis. It's a kid who isn't necessarily in a mental health crisis, but doesn't have a place to be. Perhaps they had a DCF foster placement that fell through, or there was an unsafe situation and DCF can't find a place for them to be. And so they stay in the emergency room as well. And sometimes kids wait for placement long enough that we stabilize them in the emergency room. So they don't always end up going to placement. And that is because we have child psychiatry in our department only, our hospital only, you know, that other hospitals that doesn't exist. But I mean, we have stabilized fully manic teenagers or psychotic teenagers in the emergency department because they've never, I mean, stabilized, it's all relative, right? In the emergency department because they never got to the level of care that they should have had on day one. So I guess that's kind of it in a nutshell.
Go upstream.
Yeah.
Yeah. Any other questions for Dr. McGowan? We look forward to your written testimony and hopeful that we could have you back or at least comment as we go forward with our discussion.
Absolutely. Thank you so much for having me.
Thank you. And we'll try to get Christian Pulcini in. I know he's very accomplished as well.
Yeah, we're a good team.
Thank you. Yes, you are. Thank you. Okay. Oh, we'll move on to Karen Curley of Washington County Mental Health. Thank you for being here.
Good morning, and thank you, Madam Chair and committee members, for allowing my testimony today. I'm hopeful that my testimony will complement the testimony of Dr. McGowan and other folks who have already spoken prior to me as well. For the record, my name is Karen Curley, and I'm the Intensive Care Service Director at Washington County Mental Health Services. I'm also the chair of the Designated Agency's Emergency Service Director Group, and I have written testimony that I will submit to the committee. I understand your committee has heard testimony about the current crisis in Vermont's mental health system and has been informed from multiple sources regarding the immense pressures within our system. I will highlight the dire situation by saying, as of this morning at Central Vermont Medical Center, we have a 14-year-old boarding in the emergency department who has been there for 18 days, as well as a 16-year-old who has been there for 14 days with no end in sight or disposition for either of those situations. So just to highlight what Dr. McGowan was talking about. As the rest of the system experiences debilitating distress with staffing issues and facility closures, emergency services is left to handle the resulting crises. Vermonters rely on 911, the emergency department, and mental health emergency services to respond 24 hours a day, 7 days a week, 365 days a year. I understand Bill S-197 is about developing a new coordinated mental health crisis response working group. What I can attest to as a clinical psychologist who has worked in community mental health emergency services for 23 years is good communication and collaboration between mental health responders, law enforcement, and healthcare providers is of vital importance for the best crisis response. I know you have heard from many people about what is not working in our system and why our system is currently in such an immense crisis. I think when considering whether there should be a new work group, it's also important to hear what does work in our system for crisis response and coordinated efforts among providers that are currently happening. As an emergency service director, I believe the best and most effective mental health crisis response is with a mobile outreach team. At Washington County Mental Health, our emergency screeners have been a mobile team for more than 30 years. We have 2 screeners on call 24 hours a day, 7 days a week. Our screeners meet with people in their homes, at schools, and on the streets, among other locations. My designated agency emergency service partners around the state also have developed outreach models to meet the needs of Vermonters in crisis. Within the designated agency system, we are facing an immense staffing shortage for these teams, these mental health emergency screening teams across the state. A screener on my own team came to me earlier this week and told me that they are considering working at a hospital for a lateral position for $15,000 more annually. They want to stay within our screening team and they love the work that we do, but they can't afford to continue for our salary. I strongly believe if we could pay our emergency screeners market rate and fully fund mobile mental health emergency response, we could stabilize this essential workforce. Strong collaboration and communication between law enforcement and emergency mental health responders is also essential for a successful mental health crisis response. In August 2020, the Department of Mental Health, the Barrie City Police Department, the Montpelier Police Department, and Washington County Mental Health worked together to develop a position for a mental health crisis response clinician to work in our police departments. We hired a social worker who works 20 hours per week at Barrie City PD and 20 hours weekly at Montpelier PD. The position has been an immense success for everyone involved, especially the people who are receiving the joint crisis response. Our emergency screeners have always worked closely with the 6 police departments in our area and consistently provide mobile outreach services jointly with law enforcement. Currently, we are beginning interviews for a mental health crisis specialist to work at the Vermont State Police Middlesex Barracks. Unfortunately, the statewide use of force policy has been incredibly challenging for all mental health emergency service responders, as our law enforcement partners have altered their response patterns for mental health calls. This has left mental health screeners in vulnerable positions to provide the best crisis response in situations. Team 2 is an extraordinarily important statewide training effort that is key for all law enforcement and screeners to attend. Team 2 provides an organized, respectful forum for emergency service responders to talk through best practice in a team response and to discuss challenges presented with issues such as the new use of force statewide policy. Collaboration, communication, and joint response by mental health emergency responders and law enforcement is essential for the best outcomes in crisis response. Communication and collaboration efforts between emergency department healthcare providers and mental health emergency responders is also critical for best crisis response. Washington County mental health screeners work incredibly closely with our partners in the CVMC emergency department. Our screeners are present daily in the emergency department to see people in need and consult multiple times a day with the emergency department staff as well. The CVMC staff and our screeners work as a team every day to solve impossible problems through effective communication and teamwork. Crisis bed facilities also play a key role in the continuum of care for the mental health system. Good communication and collaboration between emergency screeners, healthcare partners, and crisis bed facilities is imperative for the most successful outcomes. In Washington County, CVMC Psychiatry works closely with our crisis bed program, Home Intervention for Hospital Step-Downs, which are when a hospital patient can safely leave the hospital, but are still in need of an intensive level of treatment with 24-hour awake staff. Throughout our state, we are facing an immense staffing crisis at our crisis bed programs. Some statewide children and adolescent crisis bed placements have had to shift to a Monday through Friday model only because they cannot fill staffing vacancies for weekend shifts. At Home Intervention, we have also had to decrease our census in the past 4 months because we cannot fill our vacancies. We pay our staff $17.34 an hour. I believe if we could pay our staff market rate comparable to state and hospital pay rates, we could fill our schedule and increase our census. Crisis bed facilities are an indispensable resource in the mental health system of care and reduce emergency department wait times. They are a key team member in our collaboration efforts. To really make a difference in our current system, there needs to be both enhanced coordination among emergency service providers, as well as a significant and sustained investment in the entire community mental health system. Proactive outreach efforts prevent higher levels of care that are more expensive and are currently saturated. Outreach models are shown to be best practice and are proven to be effective. Community outreach positions need to be paid fair market value. If there continues to be a growing spread between the hospital and state clinical staff with the community mental health staff, we will not be able to hire our positions, which will further exacerbate the current crisis and continue the dependence on higher level of care. Communication and collaboration is crucial in emergency service response. The situations we face are complicated and multifaceted. Being a part of a multidisciplinary team that can communicate effectively across all emergency response disciplines provides the absolute best outcomes in crisis response. My recommendation to your committee would be, if there is a coordinated mental health crisis response working group developed, that it be a small group with a clear focus to produce results and enhance crisis response efforts. If the group is too large and too diffuse, it will be impossible to utilize the time effectively to effect change and enhance collaboration and communication for those of us out in the field providing that crisis response. With that said, I would respectfully request that if a working group is developed, there should be a designated agency emergency services representative, and I would be happy to volunteer to be that representative. Thank you for your time today and for listening this morning. I welcome any questions now or at the end of all testimony. Thank you.
Yeah, thank you, Karen. That was terrific. And it would be very helpful to have your testimony in writing. Thanks so much. We hear you and we've heard everyone. This is great. This is such an opportunity for us. I will say that I did reach out to our Joint Fiscal Office asking for a comparative analysis of what mental health counselors at the Department of Public Safety are being paid as compared with those in our community service organizations. I haven't heard back yet, but okay, well, because it seems to me that just my final comment on that is that when I hear the Department of Public Safety has just hired 9 people and they're ready to hire more, there's got to be a reason for that. Mm-hmm. And it feels like money. So Karen, maybe you can help me.
I sure can. So the Department of Public Safety, those 10 positions around the state are funded through the Department of Public Safety, but there's contracts with the designated agencies. So we actually are the entities who are providing the supervision, the training, and the support while the folks are based out of the barracks. Those folks are still paid at the community mental health center rates. So the issue is, again, that at states, hospitals, or schools, you can be paid more money for doing clinical work at any of those entities more than in community mental health. So that's the same thing for those outreach mental health clinical specialists.
Thank you. That's very helpful. And you may want to add that into your testimony. It would be great.
Sure, I would be happy to.
Terrific. Okay. All right. We should move on, and we'll come back, and if anyone has questions at the end of the testimony, we'll see what we can do there. Tina Manning and Zachary Hughes are both here. You're together, and thank you for being here. We welcome your testimony.
Thank you, Madam Chair and fellow committee members. I guess I'll start us off.
Introduce everyone.
I'm sorry. I'm Zach Hughes. I'm the assistant team leader here at Maple House and other peer support needs. This is Tina Manning, team leader of Maple House, and what else?
And peer support.
And this is Penny Martin.
I'm the director of recovery and peer services for Washington County Mental Health.
Thank you.
With our masks on, can you hear us well enough?
We can, as long as Zachary and Tina speak pretty loudly. I think we can hear you well.
Okay. So actually, Tina, you want to go first with the peer support side of it?
So are we going to do Bill 195 first?
Yes, that would be correct. Yeah. So Tina will go first.
I just want to bring to light that it just shows that Maple House is not credited for anything.
You're doing this one.
Sorry, it's easier.
So peer services.
Peer services, sorry. Which is Maple
And
House.
certification.
For certification. Sorry. Washington County has employed peer staff for over 30 years. 20% of our staff are peers
Within the CSP
within the CRT program. Within the CRT program, we have peers embedded into 14 programs. Between the year 2018 to 20, peers have provided more than over 26,000 services. This number doesn't contain to the trainings that provided through services as part of the Sunrise Wellness and Maple House Chefs.
So
The number,
basically, essentially, the services of the fact that we provided more than 26,000 services within a 3 fiscal year span does not include the hours that are attributed to those peers that are working within our Sunrise Wellness Center, which is a day treatment program, Maple House, which is a peer-run crisis bed, which you'll hear about a little bit more in a minute, and trainings that the peers help in the community. So we have peers that have been assisting in trainings with our community partners, such as Down Street Housing and Development, Capstone Community Action, and other organizations where they help people and learning how to work with people in crisis, whether they're consumers of Washington County or not. And so the peer programs, part of our peer education program is that. And there is no services attached to that. You can't actually count those services within the 26,000.
sorry, I get a little nervous when I have to talk in front of people. I'm sorry.
Listen, you're doing just terrific, and we're just want to hear what you have to say. So just
Okay.
take it easy.
Washington County requires all agencies trainings as well as WELI, which is new, which before it was called NAPI. NAPI just, you know how to protect yourself if somebody is coming after you so you don't get hurt.
As well as
diffusing. We also, the peers take the intentional peer support and wellness recovery plan, which is a WRAP. So when somebody comes into our crisis bed, that we can help them maybe do a WRAP plan, do a little bit of DBT, dialectical behavior therapy. Washington County has a peer staff consultation group to help navigate staffing questions and concerns. The peers, there are a certain amount of peers that are also part of the grievance process. Due to our lengthy history of employing peers, we feel Washington County will be a great asset to creating a peer certification program.
So Washington County agrees with the idea of creating a certification program. Some programs within other states make it very difficult for peers who are also receiving services to complete some of the trainings due to college courses that are required, and basically takes some of the grassroots methods out of it by doing some of the more traditional treatment options rather than just having a conversation face to face. So Washington County Mental Health has peers that are working in all aspects of our program within the CSP, including managers and substance abuse treatment, community living coaches who go out and help people learn how to clean their houses so that they can live independently, as well as grocery shop, pay bills, things like that. And there's peers on the medication oversight program where they go in and help people take medications in their homes. And those are all very important. Grassroots help is very much needed in terms of that whole one-to-one, you're a human, I'm a human, nothing without us kind of attitude And our peer program within the CSP is vital to our functioning as, a successful organization. So we are in agreement of making the certification program for peers.
Is it possible for you to finish up within the next 4 or 5 minutes?
Yes,
I
ma'am.
know
Yes.
we haven't heard from Zachary yet.
Yep. And
And
so why don't we hear
because
from Zach about Maple House?
Yes, please, that would be helpful.
And I can try to get through this relatively quickly.
Zachary,
What I-
is there any way Zachary can get closer to the microphone? That would be
We're
useful.
moving up.
There you go. Good.
There you go.
You probably want to take off your mask.
Go ahead and take off your
Very
mask.
well.
All right.
Good morning. Thank you for receiving me. And first of all, committee member Senator Lyon, I agree with you that there's more available for peer services out there than maybe advertised. And one of the things I'm going to talk about, is Maple House. I've been in the peer program here at Washington County, worked here for about 22 years at this point. Plus a few other years worth of peer service. So I'm just going to go into Maple House. Maple House is really a second bed in the state. It is as far as a peer bed, it is in the designated agency situation, which is really unique. We feel it's unique because to our knowledge there isn't peer beds in other designated agencies. But I wanted to give you what Maple House data we have real quick, starting in 2013. And we'll just go through my quick bullet list here. We opened in February of 2013. We conceptioned in 2012. Since that time, we've had 260 unique individuals, 411 episodes of care. 51% of all admissions were diversions from higher level and more expensive levels of care. Over 70% occupancy rate, with the highest being 95%. We provide peer respite and crisis management in our bed. And we've served many different cases. We really provide support if needed around activities of daily living or support in general. Medication support if needed, along with the agency connection here with other services. And this really allows the person to be able to re-engage if they want to, do that, and stuff like that. We remained open during the pandemic. In addition, we provided other peer services during the pandemic. In April we moved to a new facility, which is right next to Sunrise House here, which we feel kind of meets the idea of a community center here, during the day. And it's very cool to have that. And basically, we've been taking, as with the others, I think we've been taking higher acuity guests. So we've been taking some challenging cases. And what I just want to, leave you with here is that we believe that there are plenty of options out there, and there should be. That's my position here. Thank you.
Zachary, thank you. And also, thank you, Tina. Can we get a copy of your testimony sent to us? That would be very helpful.
Yes.
Yeah, this is new information for us, so we appreciate it. We appreciate the time that you've taken out of your day to be here.
We appreciate your time.
And we are aware that people were not familiar with the fact that Washington County Mental Health does have a peer-run crisis bed, and that it has been, and it's currently connected to a community, what you would call a community center, but our day program. So Sunrise Wellness Center.
Thank you.
Thank you.
Okay, I know that we're probably going to have questions going forward, but I'm going to ask Dan Toll, is it Toll or Towel? Anyway, Toll probably, for you to offer your testimony. I know I said 5 minutes, but if you can do it in 4, that would be terrific. You were the last person to sign up for testimony, and we do want you to have the time to go forward.
Okay, well, thank you so much, committee members and Madam Chair. We'll really try to keep this to 4 minutes, but I'm afraid it's going to be very challenging. Thanks for inviting me and for your patience with me as a neophyte advocate here at the State House. Again, my name is Dan Toll. I'm a psychiatric survivor here in Montpelier. Moreover, I'm a mental health peer support law enforcement management consultant, a frontline peer worker volunteer for Pathways Vermont and NAMI Vermont, and an advocate for those with mental health conditions on such statewide committees as the Adult State Program Standing Committee, vice chair of the Peer Workforce Development Initiative, and a member of the Montpelier Police Review Committee. As a champion of peer support, I'm here first to address S-197 and secondly 194. I'd like to offer testimony on S-197 regarding the working group to evaluate how we handle mental health crises and develop a better way. I'd like to present some suggestions to consider as you debate this bill. As I laud your attention to create a working group to study this issue. In my humble opinion, there's no more important issue than reforming our crisis response system. Our goal needs to be dealing compassionately in a trauma-informed, person-centered way to mental health crises. So while the underlying motivations behind this bill, I think, are spot on, I'd like to offer some suggestions for your committee to consider as you debate this bill. So first, in line with Karen Curley's comment, I also would respectfully urge you to consider how best to utilize state funds between this new crisis response working group and then current initiatives that are underway and promising new approaches. Already so well articulated by Laura Olin, the AHS recently hired consultant to work on the quote technical assistance for community-based mobile crisis with a budget of $780,000. It's one current initiative. Second, as mentioned earlier, the work of our first mental health director of DPS to recruit and hire embedded specialists in the barracks in the context of evaluating chronic crisis response across the state. The wonderful work of people like Kristen Chandler and Team 2, and of course, emergency crisis services of the DAs, as so well articulated by Karen. In addition, as mentioned by Laurel Olin in her testimony, certain jurisdictions in Vermont are considering taking the next step in the evolution of crisis response, which is adding, as mentioned earlier, a peer response crisis worker as the third leg of the stool of law enforcement, social worker, clinician, and peer support crisis worker. There are cities and states across the US, they're starting to deploy this emerging best practice. For example, just yesterday, I spoke to a mental health leader in rural New Mexico, and they've successfully implemented a crisis response model with these 3 components. But the peer support crisis worker, there was initial pushback from the police, but over time, they demonstrated their value added and not only were requested to be part of dealing with crisis response, but also in conjunction with the social worker, actually provide counseling confidentially to the police themselves. So in summary, I support the idea of the working group, but as Karen mentioned, a more focused group and doing that in the context of things that are going on initially, I'd urge you to consider those. Consider finding the balance.
We hear you, and we've heard that message loud and clear today. This is extremely helpful. Thank you.
Yeah. Secondly, I wanted to offer my own personal experience as focusing specifically on one of the second bill, S-194.
Can I ask you, I don't like to do this, and I don't usually do it, but can you wrap this up within 1 or 2 minutes, please? And only because I know that you came into testimony late, and I'm hoping that we'll be able to get your testimony in writing, but go ahead. And we have one other person who's waiting to talk today. Go ahead.
Okay. Well, I was going to talk a bit. I was going to talk about my story relative to the peer respite and also the community center. Maybe I'll just focus on one piece of this, and that's the community center. I wanted to relay my personal experience with another way. I moved to Vermont 7 years ago, and it was a very difficult period for me in terms of my depression. I didn't know anyone, didn't have any friends, and then I found another way. And right from the start, as I stepped in the door, I was welcomed. My mental health struggles were validated by the peers, and I started attending community meals, taking yoga, art therapy. Another way essentially helped restore my self-confidence and bolster my hope of a new life and new relationships. And in my early times in Vermont, in Montpelier, proved to be a real lifeline. So as respects S-94, just a snapshot into how value a community center can be as part of our community mental health response. Thank you.
That was absolutely terrific. Thank you. And we really appreciate your testimony. I know that you asked to testify late in the game, but it is important that we've heard from you. And as we're going forward, we may reach out again. So thank you for being here. And we look forward to having your testimony in writing.
Great.
All right.
Thank
Thank
you.
you, Dan. Okay, good. We have one other person. Aaron, do you want to admit? I will. Okay. Christy, thank you for being here. Not the tennis player, but not the tennis player, but the licensed clinical social worker. And you are here for Mental Health Advocacy Day, and it's kind of serendipity that we were taking testimony just now on our mental health bills. So thank you for being here, and we look forward to your testimony in celebration of Mental Health Advocacy Day.
Well, thank you for letting me join you today. And I know that I think I'm the last one testifying today, and I hope to leave you with a little bit of a hopeful message at the end. I did send some information earlier to Aaron in case I don't get through everything. You do have some additional information available to you today. But first, I just like to thank you for the opportunity to speak today. My name is Christy Everett. I am not the tennis player. I am not that good, but I am the director of operations here at the Clara Martin Center, which is the designated agency for Orange County. I am here to speak today in support of Mental Health Advocacy Day and want to focus really on 2 items to share with you. To begin, I do want to address the extreme crisis in workforce the DA and the SSA system is facing currently, which I know this committee is aware of. Members of our system have testified for years on what the effects of the system will be if it remains underfunded. The fact that the system has even weathered a global pandemic should be commended and is a testament to the bedrock strength of what it is capable of, but it will not last without a significant investment from the state this year. There are over 1,000 open positions across the DA and SSA system. I was speaking to our human resources director last night, if she could just give me sort of an update on numbers. We have 143 full-time salaried staff, and we have 43 full-time openings. That's a 30% vacancy rate at this point that we're working on filling. That's the highest it's ever been at this point. And that's just strictly an inability to offer competitive wages when compared to other healthcare providers in our area. We are interviewing, we are offering, and people are just flatly turning us down because they cannot take it for the wages that we can offer at this point. I know Governor Scott has included a 3% rate increase in his budget. I respectfully ask the committee to give serious consideration to a 10% increase at this time. The system needs that to at least even start with. One of the questions is, how do we address immediate needs and how do we address the long-term sustainability? I'm proud to be able to share with the committee the work we've been doing at Clara Martin Center as the first certified community behavioral health clinic in the state of Vermont. The CCBHC model requires clinics to make 9 core services available to all individuals. And I'm not sure how familiar folks are with the CCBHC model, but the model does require that every clinic requires these 9 services: outpatient mental health and substance services, crisis services, screening, assessment, and diagnosis, patient-centered treatment planning, psychiatric rehab services, so psychiatry for those who are on addictions services, mental health care for veterans, peer support, counseling, and family support, targeted case management, and primary care screening and monitoring. Because the purpose of the model is to increase access to care and improve quality. Care coordination is supported and encouraged amongst providers, with those efforts able to be funded under the grant. And with a focus on easing eligibility standards for services to increase access, we've been able to provide more services to more people who would be considered ineligible under current structures. An example of this is vocational support or case management. Currently, in order to provide these supports, someone needs to meet eligibility criteria for us to be able to provide the service and receive funding. Under the CCBHC person-centered structure, if those services would benefit the person and they are requesting those supports, we can now provide them and get reimbursed for the staff time to provide them, which has historically never been something that we've been able to do. Another example, which I think really speaks to the value of what CCBHC can do, is the issue we face providing therapy services to those on Medicare. Currently, Medicare will only cover therapy for the individuals if they are seen by an LICSW. Under the CCBHC model, if there is no LICSW available to see someone with Medicare, they can see any master's level clinician, which vastly expands our ability to reach this underserved population. It just removes sort of that eligibility standard that has hindered a lot of the providers from being able to provide that care, because it really focuses on easing access into services. So the big question really is, how does this all get paid for? The funding under the CCBHC model allows clinics to be reimbursed for their total cost of care, similar to the FQHC model under a prospective payment system, and brings a higher level of Medicaid match into the state. It's usually 65% Medicaid match in normal times, which during the pandemic has actually been increased to 73%. And it's an even higher Medicaid match rate for emergency services, which I believe is around 80 to 85%, which can actually help go to pay for things like your 988 implementation in clinics, which could be a little bit of a game changer as well. This only occurs though if the state of Vermont applies to join the federal demonstration program, which will be an option if the Excellence in Mental Health and Addiction Act passes. Congressman Welch has signed on to that act. We've been in conversations with Senator Leahy and Senator Sanders to sign on. Senator Leahy has been one of the original sponsors of the Excellence in Mental Health Act, which was signed in 2014. And he has routinely signed on to the renewal of that act every single time it's come up. My assumption is that he would continue to be a co-sponsor of that renewal when it comes up and sign on to this one, but we will continue to be working and conversing with their offices as well. So that is an option. The other 2 options in which this can occur for the CCBHC to be implemented statewide is if CCBHC services are included in the 1115 waiver or a state plan amendment. We've been discussing these options with the Department of Mental Health. They're currently doing their own vetting at this point. In the information that I did send you earlier, I've included some preliminary data because we got this grant in February. We started providing services under the grant in June at this point. And what the data that I sent you is really all services that the grant has been able to provide over and above services that we were able to provide under any DMH or ADAP funding. So from June 15th through January 31st, because I just ran these the other day, just for an example, we did 3,733 additional services that the grant allowed us to fund, above and beyond what DMH and ADAP and other services did. That was anything from therapy, mental health care, case management, medical care. The grant allows us to put nursing care into our substance programming. So we have a nurse in our IIP program. We have a nurse in our child and family program. We were able to do different things. We are actively working on, we don't have a peer program here. We're actively working on hiring peer support staff who are going to be available across our agency for anyone who needs that type of service. We have hired same-day access clinicians to be available. We're able to provide transportation to clients if that's what they needed. It's really just been somewhat of a game changer for us.
So Christy, thank you. This is the grant that you have received. And so the data that you're providing is a result of that, and it would link in should an 1115 waiver or state plan go into place.
Yeah.
Thank you for bringing this to us today. Unfortunately, we are at the end of our committee meeting. So appreciate very much your information, and we'll make a decision as a committee how to follow through with this as it's needed. And we may ask you to come back in should we pick this up. We'll also be talking, of course, with folks at DIVA and DMH to figure out what their decision making will be. So we'll have to work together.
Okay.
But appreciate your time very much.
Okay. Thank you so much. I appreciate it.
Yeah. So we'll stay connected. And I know Clara Martin Center is in a wonderful little place. I visited it a few years ago along with the Gifford Hospital. It's a great place.
Thank you. You're welcome anytime.
All right. Well,
All right,
if we were making trips, that would be at the top of our list, along with the Washington County mental health folks. So thank you.
Great. Thank you so much. All right. Bye.
All right, Aaron, we're